And I think one of the challenges is when, compensation is set, it creates a floor. And then once that compensation rises, it becomes the new floor. And so that new floor, is always hard to kind of step back down once you've stepped up.
Welcome to Off the Chart, a business and medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Littrell. I'm the Associate Editor of Medical Economics, and I'd like to thank you for joining us today, and I hope you all had a safe and happy 4th of July and enjoyed the long weekend. In today's episode, I sat down with Tynan Kugler, a principal in PYA's consulting practice, to talk about the 4 forces pulling physician compensation in competing directions. We get into why a competitive offer is now necessary but no longer enough, how rising pay creates a floor that's very hard to step back down from, and what physicians tend to misunderstand about how their offers actually get built and evaluated. Tynan Kugler, thank you again so much for joining us, and with that, let's get into the episode. Tynan Kugler, thank you so much for joining me today.
Happy to be here.
So we can kind of jump into it here to the meat of what we'll be talking about. What are the biggest forces that are shaping physician compensation today?
So there are really, I'd say, 4 forces. So supply and demand imbalance is one. Continued shift to employment and system affiliation is another, or alignment with private equity-backed organizations. We're still seeing that. Reimbursement pressure. Can't not have a conversation about compensation and talk about reimbursement pressure. And then the continued interplay between productivity and value. So compensation paid versus on a productivity basis, or paid based on outcomes and quality, for example. And I'm happy to go into sort of a little bit of detail on each one of those if that would be helpful. So supply and demand, that is an area where, especially in primary care, we continue to see some persistent shortages, and that puts upward pressure on compensation, right? So when we do provider needs assessments, for example, we see pretty not drastic, but we see significant shortages. I guess some of the providers would say they're drastic in shortages in primary care. So family medicine, internal medicine, and OB, but then also some of the other specialties where we really see some shortages are neurology, rheumatology, gastroenterology, hematology, oncology, or some of the medical specialties that we typically see are seeing shortages, hospital-based specialties too. So anesthesiology and radiology. And the latter two, honestly, are some of those are needing financial assistance for the first time in that specialty's history. So that's been an interesting trend. Affiliation and employment, many independent practitioners have sought employment, but some are still continuing to seek employment or affiliation, depending on the specialty, for, quality of life, financial pressures, and it's both revenue and expense pressures. Recruitment, the inability for independent practitioners, for example, to recruit and develop, succession plans effectively. That's another area that creates obviously pressure on compensation. And then, we're also seeing hospitals and health systems want to go into developing primary care concierge practices. So that's another area that we're starting to see. And then I guess the final thing on, sort of employment affiliation is that we're seeing also a lot of academic health systems who historically maybe had, more closed models, are now going out and looking at community health affiliation strategies. So that's a way that independent practitioners are also interacting or affiliating. Reimbursement, declining reimbursement, payer mix pressures, those two are, obviously compressing margins and impact compensation. And it's not just, how much can somebody sustainably pay as it relates to, compensation to keep everybody happy, but it's also how much from a commercial reasonableness perspective, it's how much can somebody sustainably lose. So it's not just, it's the financial and economic impact, but it's also the regulatory impact on the, hospital employed side. For private practices, it's a challenge because, oftentimes it's the difference of them being able to recruit that next provider to fulfill a succession plan, or having to go request an income guarantee or other financial assistance from a hospital or health system. So, Medicare for some specialties, there's always the Medicare routine adjustments to the Medicare physician fee schedule. I think one of the things from a primary care perspective, the conversion factor increase for 2026, and the fact that even though there was an efficiency adjustment that Medicare made for work RVU, so effectively, if you're if you do surgeries or you're a proceduralist or imaging or diagnostic, you could be hit too with the impact of that efficiency adjustment because it reduces work RVU values. But primary care hasn't been impacted as much by those efficiency adjustments. And so the 2.5% increase is actually somewhat of a nice win, depending obviously on the mix of patients you see. But the other, sort of positive, I think the physicians would say is positive is, starting in 2027, the global obstetric codes, so global obstetric billing, those are going to be unbundled. So a series of CPT codes that have historically been bundled are going to be itemized into service level reporting. And so that's going to, again, we're trying to go towards sort of some of these models where payments are bundled, but this is an area where they're unbundling. And, I think, the rationale has been that it's intended to be more modern, promote team-based care, individualized care plans. And I think for OBGYNs, it's expected to have a positive impact. So it's not always all bad news, but it changes every year. And I guess the final one is just the interplay between, productivity and value. And work RVUs still remain in employed models, still remain the dominant metric. But I think what we're really seeing is that shift to more of a hybrid approach where you've got, base compensation that's competitive but supportable, and then a movement towards really making some additional compensation at risk. And, for example, some specialties are not as forward thinking in moving as quickly. I think primary care has been pretty good about adopting quality metrics. There's an organization, the American Association of Provider Compensation Professionals, and they did some research that showed that approximately or close to 3/4 of primary care organizations have adopted value-based incentives. So some good movement there, but others are a little bit lagging. On the independent side, I think the movement towards quality is really to help show payers that practices are committed to improving outcomes, and that ultimately, even though there's not as much leverage from a negotiation perspective, can translate into financial savings with outcomes. So that was a lot. Lots of trends, but compensation is impacted by all of those.
How are medical groups trying to keep physician pay competitive while also managing rising costs?
So that's like walking on a tightrope. If we're thinking about employed providers, I would say the most effective organizations, the way that they're approaching that is they're not just, simply raising salaries. So they're not on a, okay, we're going to just every year raise salaries or within the every contract period raise salaries. It's just not sustainable. And so I think the things that we're seeing there is organizations are really looking at how do we redesign our compensation model. So it's really doing a deep look at what are the things that we can do within the framework we've created to sort of redesign those models. It's leveraging productivity again and sort of care optimization, which we can talk about. And then it's thinking about the cost structure. So it's those three things. They're not rocket science, but every time we have sort of discussions about compensation, we always go back and say, what are the things that you can do to sort of get your house in order, reevaluate things that you haven't looked at in the past. And on the comp redesign side, we talked a little bit about that. It's transitioning into more of a hybrid model. I'd say for, primary care on the, employed side, it's really making sure that the base salary is competitive, while it's market aligned, but then also including a work RVU based incentive or value based metrics. And I think the way it's different than it's been in the past is there's probably on the hospital side more focus on that value or quality and, in areas of things like panel size. So what are we doing to manage our panel size, various access metrics? So things like the next non-emergent appointment, time to the next, non-emergent appointment, or time to the first new patient visit. So things like that are measurable and that are meaningful. And, that an organization has some control over from an outcomes perspective. The other thing is shorter guarantee periods. So, 1 to 3 years is a, typical. I think 3 years has historically been what a lot of organizations use, but I think to mitigate some of that cost, ratcheting that down to 1 or 2 years, and that still allows for some ramp up if that's needed, but also mitigates some of that expense. And then targeted sign-on bonuses. So bonuses that are utilized instead of, just a flat out salary inflator. So those are some ways I think that hospitals are mitigating that. Care optimization, and this goes for both independents and, hospital employed providers, are really looking at the advanced practice provider strategy. So they are just central to care delivery now. And, how either an employed model or independents are using advanced practice providers, I think it can impact compensation. It can impact job satisfaction. It can impact accountability, and one of the challenges there though is that, advanced practice provider compensation models have not historically been tied to productivity. So there's kind of a little bit of a lag there. And then sometimes physician compensation models have not taken into consideration, the work effort related, over and above when there's, kind of over and above management to collaborate with APPs. So it's kind of that push pull of use an advanced practice provider and a physician to the top of their license, but recognize that there's some levers that need to be pulled to manage both, compensation and overall professional satisfaction for both.
When finances are tight, why is physician compensation such a difficult area to pull back on?
Yeah, you ask me hard questions, Austin. And, this is one I think about a lot just because, you wish there was an easy answer and there was sort of an easy solution, but the challenge is, physician compensation, really kind of compensation in general, but physician compensation, there's an intersection of market dynamics that have to be taken into consideration. So, supply and demand, which we've talked about, legal and regulatory considerations. So, what constitutes market compensation is a consideration when compensation is set, and then just the operating realities of care delivery. And I think one of the challenges is when, compensation is set, it creates a floor. And then once that compensation rises, it becomes the new floor. And so that new floor, is always hard to kind of step back down once you've stepped up. And so that's one of the reasons why really setting base compensation and looking at kind of what your fundamental compensation model is really critical to an organization's success and how they approach comp design. And it's not just for one specialty, but it's kind of philosophically across the organization. Because, the reality is that when demand exceeds supply, then providers have other options, and employers have limited leverage to reduce pay. So it creates a situation where physicians can go elsewhere for either a different model, a different, comp model, or lifestyle or quality of life model. And it's difficult then for employers to reduce pay. They have to just constantly ratchet up, where if reimbursements flat or ultimately decreasing or expenses are rising, you just can't ever get ahead of that curve. So, the other factor in that is that from a legal perspective in the employed model, changing agreement terms, is a process. It's not just something that happens on a dime. So, terms require renegotiation. There are regulatory inputs that guide how often, compensation can change. So there are just challenges there. The piece on the market data that's important is that, even if you had a provider that said, okay, we want to ratchet compensation down, if you go out and you look at a variety of different, data surveys, so benchmark data for physician compensation, and you look, if you looked at one or a couple, but if you looked over the last couple years, and we do this, we look at the compound annual growth rate, and you see that, it's flat, or sometimes it'll decrease a little, but it's usually flat or increasing. And so when you've got, again, benchmark data is one starting point. It's not the end all be all, but when you've got that as sort of an anchor in many ways, it's hard for a health system to say we're going to reduce compensation when we know the market is flat or increasing. So it is definitely a conundrum, but there are things that organizations can do to, and we talked about a couple of them, to manage that increase and still retain their provider workforce.
Hey there, Keith Reynolds here, and welcome to the P2 Management Minute. In just 60 seconds, we deliver proven, real-world tactics you can plug into your practice today, whether that means speeding up check-in, lifting staff morale, or nudging patient satisfaction north. No theory, no fluff, just the kind of guidance that fits between appointments and moves the needle before lunch. But the best ideas don't all come from our newsroom. They come from you. Got a clever workflow hack, an employee engagement win, or a lesson learned the hard way? I want to feature it. Shoot me an email at kreynolds@mjhlifesciences.com with your topic, a quick outline, or even a smartphone clip. We'll handle the rest and get your insights in front of your peers nationwide. Let's make every minute count together. Thanks for watching, and I'll see you in the next P2 Management Minute.
Where do organizations typically have the most flexibility when structuring physician compensation packages?
So fundamentally, I would say that, organizations have flexibility really in the totality kind of how they design their physician comp model, as long as they meet regulatory requirements. So, when you think about flexibility, an organization can say, here's how I want to set my compensation structure or my model, as long as, for example, it doesn't take into consideration, the volume or value of referrals. The challenge is very few organizations are at a point where they can, sort of start from scratch. And so what they end up having to do is think about what changes and what levers they can pull, to make movement, to redesign, and to move the model forward. So, ideally you start from scratch and you have the flexibility to do that. Most don't have that flexibility. They have to kind of look and say, okay, what do I have and what do I need to do? So least flexibility is probably with base and possibly productivity metrics. And, some of that's due to the fact, as we talked a little bit about, that there's that strong correlation to just general market data. But I would say these are the main metrics that most physicians are that's important to most physicians. So what's my base, what's my base compensation? What's my opportunity for a bonus? But interestingly, some are more focused on what's my base. Some are more focused on what's the value of a work RVU. Some are more focused on how many work RVUs is it going to take me if it's a work RVU model to get that bonus, and what does that look like? So you're managing a lot of considerations there, depending on what's important to that provider that's either in a system or that you're trying to recruit, even into an independent practice. I think where we see more flexibility is in those incentive compensation options. So, I know there's a tendency to think that sort of paying for quality is a little bit nebulous. You say, okay, we'll give you payment for quality, whereas productivity, it's a little bit more well-defined. But I think there's opportunity for flexibility in compensation development with quality metrics, because oftentimes it's collaborative. Hospital has to meet is trying to move certain outcomes, and they need provider assistance to do that. And so the collaboration in terms of how we set those quality metrics can often be where there's some flexibility. Recruitment and retention is another one. So how you structure and manage the relationship of a signing bonus, a forgivable loan. Relocation expenses have a tendency to be pretty standard from what's offered and sort of what that dollar is. But there is flexibility in how signing bonuses are set, both in terms of the dollars and the same thing with forgivable loans. So you could have a situation where it's, again, being consistent, not being inconsistent with market data or with a situation that's going to create a commercial reasonableness issue, but allowing some flexibility there to meet the needs of the providers that you're trying to recruit.
What should physicians understand about how compensation offers are evaluated?
So most hospitals and health systems, if we're thinking about, an employed model, an independent practice is, a little bit different, but sometimes not though. Most hospitals and health systems will have a compensation philosophy or a, compensation guidelines. So they will actually have here is our compensation model. Here's how we set compensation. Here's how we review offers. Here's how we review compensation. Here's how we determine what we're going to offer. Here are our guardrails. And that's often approved by leadership and by boards of directors. And so there is a framework from which offers are created, determined, and evaluated. So, again, sort of those high-performing organizations will have that process in place, which, makes it more streamlined for the purposes of what can we offer. But sometimes that's difficult if a physician has never negotiated a contract with a hospital or health system, don't necessarily know that that's sort of what's out there. If, for example, they've been independently practicing or employed previously. And so the considerations is, so after you kind of get past, hey, we've got these guidelines, then it's how do we analyze and come up with what the offer is going to be, and there are multiple considerations depending on the different circumstances. So, and that physician or that provider situation. So, for example, you could have, an experienced physician who's moving into a new market, so into a new community. That physician offer, even within those guidelines, could be evaluated differently than, a new physician coming out of residency who may be coming into that same market, but that physician's going to be evaluated, and that offer is going to be evaluated differently than a physician owner who may be in private practice, but who said, I don't want to be in private practice anymore. I want to affiliate with a hospital or health system. There are different considerations to think about there too. And if we just think about high-level examples, that experienced physician new to a market is going to have historical compensation, but that productivity might not directly relate to what that market is going to look like. So that insight has to be taken into consideration and, insight factored and then thought about through the scope of the organization's compensation model. That new physician coming out of residency isn't going to have historical productivity or historical compensation, but is being recruited and maybe has significant student loans to pay off. So those facts are different, and the insights of that circumstance are then factored into and evaluated within that same scope of that organization's model. And then if you go to that owner physician who's currently in the community, has historical productivity in that community, knows what he or she's been paid in that community. So we've got history there that we can then translate to what does this look like under this hospital employed model. 3 different situations working under the same framework, but with different potential, considerations because of the perspective of what that physician has done and will be doing. So once those kind of, facts and circumstances are identified, usually what will happen is the historical compensation, if it's available, and productivities, it's evaluated and reviewed. And we do start with benchmark data, typically, multiple benchmark surveys. And so that historical compensation can be benchmarked to say, what's this provider made in the past, just to get a sense of, okay, where are they? The proposed model often gets, benchmarked and looked at and reviewed to see where that falls. And if the benchmarks are favorable, again, benchmarks are a starting point, a factor. But if, for example, compensation is supported by production, if the various other benchmark data points that we would look at, for example, are in alignment, and then there are other facts and circumstances that we review to say, is the offer supportable? So is there a deficit for this specialty? Has the hospital been, or even the practice been, looking to fulfill a position for a period of time? So have they been having to use locums? And again, if it's deemed to be commercially reasonable, then the parties proceed typically with, a letter of intent and onto a contract. But it usually starts with sort of what's our approach to comp, what's our comp philosophy, what's our model, and then how are we going to take these facts and circumstances and run them through the model that we've developed that will result in hopefully a competitive, compliant compensation model that incorporates both the provider needs, the hospital's needs, and ensures that from a retention standpoint, that provider can be part of an organization for a period of time.
Is there anything else that you think physicians should understand about this issue? Anything I didn't ask about I might have glossed over?
Yeah, just a couple things. Not all roles are equal. So compensation components are evaluated based on specific facts. So whether that's base salary, quality, recruitment incentives. So that's important to take into consideration. Alignment matters as much as compensation. So the goals of alignment are really important. Understanding that the structure of a compensation model should align with how a physician works. And then, probably don't need to say this, but compensation is complicated. There are lots of different forces that go into play, and it's important that everybody go in with it knowing sort of what it is they're trying to get out of it, what can give, what can't give, and collaboration is key.
Excellent. Well, Tynan Kugler, thank you so much for your time today.
Appreciate it.
Once again, that was Tynan Kugler, a principal in PYA's consulting practice. On behalf of the whole medical economics and physicians practice teams, I'd like to thank you for listening to the show and ask that you please subscribe so you don't miss the next episode. As always, be sure to check back on Monday and Thursday mornings for the latest conversations with experts sharing strategies, stories, and solutions for your practice. You can find us by searching Off the Chart wherever you get your podcasts. And if you'd like the best stories that medical economics and physicians practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at medicaleconomics.com and physicianspractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Littrell. Medical economics and physicians practice are both members of the MJH Life Sciences family. Thank you.